So thank you, Dr. Mains, for speaking to us.
You're very welcome.
So can you please start by telling us a little bit about what is psychodynamic psychopharmacology? Because to some it might seem like an oxymoron to say psychodynamic psychopharmacology.
Yes, exactly. Well, that's where the name came from, was recognizing the oxymoron and the tension between those things. But as you said, at the Austin Riggs Center, I specialize almost entirely in patients that are complex, comorbid, and have failed multiple medication trials, and part of the context, I think, of that is the environment in which we've been practicing, right? A generation ago, or maybe a generation and a half ago, there was a psychoanalytic model that held sway, which had its own limitations in terms of missing the patient's biology sometimes. But there was a hard swing into a much more biological reductionistic practice where the solution to a problem is to add another medication. And once you've had a dozen medications that haven't worked, you have to start wondering, what's the problem? And so part of what we've developed here at Riggs is an understanding, backed by, I think, plenty of research, that a substantial part of the effects of medications are really mediated by psychosocial factors: the patient's psychology, the doctor-patient relationship, the patient's environment. So psychodynamic psychopharmacology really is just a way of thinking, particularly about treatment-resistant patients, and considering how does that patient's psychology in some way end up interfering with the healthy use of medications. And then from that we developed a number of basic principles of what do you do when you're dealing with somebody who's treatment resistant, to bring those to light and begin to work with them. Because chances are just giving another medication when somebody's already failed a dozen of them is not going to be enough.
Yeah. I think that I think that the term treatment resistant is interesting also. There's another type of tension that I notice, is whether we refer to the patient as treatment resistant or to the illness as treatment resistant. So do we say this is a patient with a treatment resistant illness, or do we say it's a treatment resistant patient? Might reflect our view of whether it's the biological problem or it's a psychological problem.
Yeah, and exactly, and it's another tension or in this that I liked. I used the word treatment resistant for specifically that reason, because it highlights, and when the field is maybe moving towards treatment refractory, treatment resistant highlights that it may be resistant in the patient. And I think actually there's probably two kinds of treatment resistance that patients can end up with in relation to medications. Some patients are treatment resistant to the medication.
Yeah.
Right. So there are reasons in their psychology that they have to fight it. Whether the symptom actually provides them with some benefit that they actually need. Not that they necessarily became ill because of that.
Yeah.
But when life gives you lemons, what do? You make lemonade, and people can get attached to symptoms because they serve some need. I think I could say certainly in my practice, many of my patients who are treatment resistant are far more powerful as sick people, right, than they ever were as well people. So as prescribers, we're dealing with this. We're dealing with massive, but often unconscious reasons for the patients to fight us. And patients may also be resistant to medications just because their experiences of caregiving from throughout their lives expose them to be distrustful, to worry about being controlled, and so they may fight us on that account. But I think patients can also be treatment resistant from the treatment that they get. We can prescribe in ways that are deauthorizing, de-skilling. A lot of patients, particularly patients I think that have been on medications from the time they were very young, can end up losing a sense of agency, right? When a patient comes in and, I think one of the worst prognostic signs is a patient comes in and basically turns himself over to you, to the doctor, and says, fix me. As if the patient has no resources that can be brought to bear in their recovery. Right? And when we collude with that, we end up with people that are passive and deprived of a certain amount of agency. The other aspect of treatment resistance is is the treatment resistance that derives from what the doctor is doing, and I think that's an important part of it as well. And whether it's when we end up colluding with something that is deauthorizing, or Elvin Semrad once said of psychotherapy, and it's true of any psychiatric encounter, that the psychiatric encounter is an encounter between a big mess and an even bigger mess. Right.
Right.
And so, we're also,
hopefully we are not the bigger mess. We are the big
but not
mess.
always. And our patients are filled with, with really dysphoric affects, and they can do a good job of giving us a good dose of what they're feeling. So they fill us with hopelessness and helplessness, and so we can also be pushed into doing things that are irrational. When we're prescribing to lessen our own discomfort. There's a good chance that probably won't help the patient and actually contributes to treatment resistance. Right. And of course, that's part of what's psychodynamic, is a perspective that we are all, doctors and patients, pushed around by unconscious factors.
So I'm filled with questions based on what you said. So I wanted to clarify a couple of terms. So you said deauthorizing. By that, do you mean that the patient feels that they are passive? Is that what you mean? They don't have the authorization to take charge of their problem?
Yeah, they don't feel like they're in charge of their lives. They don't feel like they have the answers. They feel like you have the answers.
Yeah.
And it really is a terrible position from which to try to get better.
Yeah. And then can you please clarify a little more about the term de-skilling that you use? What does de-skilling mean?
Well, again, consider somebody who has been on medications from a time they're fairly young.
Yeah.
And so whenever they get upset, they take a Seroquel.
Yeah.
That person learns that when you're upset, you take a Seroquel. What you and I probably learned is a set of other skills to manage our feelings, to, things that people end up learning in various kinds of therapy. But when people turn so readily to medications, it can really prevent the development of other skills that are really crucial for living.
Right. Okay. Now you said that when patients present themselves from a viewpoint, from the position of being passive or helpless, then the prescribing clinician may collude with the clinician and sort of support that view. So, in what would be an example of us colluding? I just want to make sure we are clear. What would be an example of me colluding with my patient to make the patient passive?
And I will say, I think there are probably some good reasons that we collude too, because one of the things we know is that the more enthusiastic we are about a treatment, the more likely it is to work.
Yes.
So there's good evidence on this. Yeah. So one of the things that we do, I think, when patients come in is we say, I can fix you. This is the thing. Your biology is this way, so I have the right medicine for you. Yeah. And what we do is we position ourselves as the answer.
Yeah.
And I think that probably is not a bad idea for somebody who's just getting into treatment.
Yeah.
When somebody has really demonstrated they're treatment resistant, I think the more we do that, the more they end up looking to us for the answer, and not having in a sense that this is something that we're both in together. That I'm going to do my part, and you, the patient, have to do your part.
Yeah. Okay.
So one way we do that is just by in our claiming in a way that this is the thing that's going to do it.
Right. So I found that point helpful. What you said is that it depends on what kind of patient we are dealing with. If in a treatment-resistant patient, we should be more alert for this kind of phenomenon where the patient is presenting himself or herself as very passive and helpless.
Yes, absolutely.
And idealizing us, perhaps. I mean, I certainly, as a specialist in psychopharm, I get patients who come and say, "Oh, Dr. Margo, we've heard such a lot about you, and we are told you're an expert, and you will know exactly what to do." So, yes. So the temptation is to think, "Oh, yes, I am great." Yeah.
Yes, of course.
I am great. You are right.
It's funny. One of the tricks that I've developed, part of my pattern, the patients that I see at Riggs. Typically, they have seen the psychopharmacology gurus in the big cities.
Yes.
They've been told this by the experts.
Yeah.
And so I really am working at developing an alliance where we are much more co-investigators, where we are much more well, I have my areas of expertise. The patient has their areas of expertise about who they are and what they want.
Yeah.
But one of the things that I will sometimes say, especially to a patient who is looking to me to be an expert, who's trying to position themselves, I think, in a more of a passive role that they can receive than my expert caregiving, is I will point out the complexity of this. I will say, the psychological factors are so complicated that if you get better, if you have a good response, it's really hard to know. Is it because of a psychological thing, a medical thing? And so I'll say part of my expertise is in not knowing.
Huh.
Because then that positions us that it's up to us together to grapple with these questions of what part of your recovery is related to intrinsic qualities or psychological qualities, what part of it is related to the action of medications. And I really do think it is always so complicated that we never know for sure.